We're excited to be.
So my name is Lori Sperduto Cox. I'm the supervisor at the Kirker Center for Child Development. I have been a practicing speech language pathologist for 18 years. I'm also internationally board certified in lactation. And, both work here at Valley. We both work inpatient at Valley, seeing pediatric inpatients in both the NICU and the pediatric intensive care unit. And we do feeding evaluations, speech and language evaluations, as well as treatment here at the center.
I'm Meredith Hudson. I do the exact same.
Okay, so we'll start our presentation. I'll share my screen with you and we'll get going. Okay, so our presentation, could it be a tongue tie? Like we both said, we're both speech pathologists. Lori is also a lactation consultant. So we help people all the time with bottle feeding, breastfeeding, transitioning to solids, chewing, talking, picky eating, cup drinking.
Yep.
All of it. So let's get started. Next.
Well,
in any minute. Oh, there we go.
Okay. So the topic of our presentation is tongue tie. So we're going to first define what a tongue tie is. So we also provided pictures in some of our slides so that could help you guys get a good sense of what we're talking about. But the first and most important thing to remember is that everyone has a lingual frenulum. And if you refer to the pictures at the bottom of this slide, both of these pictures are showing normal variation of what a lingual frenulum is. So just because it looks like there's some level of tightness, it's all about function. So a lingual frenulum is the part of the tongue that connects to the bottom of the tongue. It connects the bottom of the tongue to the floor of the mouth. So you can see in the first picture, there's whitening or blanching of the lingual frenulum. So that one's a little bit shorter, but yet you can see that there's functional range of motion of the tongue to reach the top of the mouth or the palate while the mouth is open. In picture number 2, it doesn't even look like there's a frenulum because it's much looser and there's even more range of motion. But what we want to make sure we drive home to you guys is that everyone has one and they're all different. So in abnormality, short or tight lingual frenulum may restrict tongue movements that may impact function for both feeding and speech. So that's what we're looking for. So when we evaluate or assess a child's mouth, we're looking at not only what the child has in terms of their range of motion and their ability to move their tongue, but we're looking at the function and how they can use their range of motion. So there's many different degrees from mild to severe tongue ties. Mild tongue ties are where the tongue is connected by a thin mucous membrane. And you're going to see in the other pictures, if you're not 100% sure, but definitely picture 1 shows that membrane. And then the severe, whereas almost the whole tongue is anchored and there is not much of a great ability to elevate the tip of the tongue. Okay.
Okay, so this is the picture that Lori was referring to that we'll have some throughout the presentation. So how do you know, right? Is it too tight? Is it too short? Is it impacting function? How do we figure that out? And that's our job. So some shorter or tighter lingual frenulum do not cause any functional impact to the tongue and can be left alone. And they're tighter, they're shorter, but there's no function impacted. Speech, feeding, everything is great. There's no reason to do any intervention of any kind. However, if function is being impacted, you might see some of the following difficulties. You may see problems with feeding, whether it be breast, bottle, other stages of feeding development as well. Maybe mom's in pain while nursing. You might see some increased signs, symptoms of reflux. And I spoke to this before, when we talked about also other things we work on with kids, you might see some difficulties along the line as the child progresses in their feeding development.
So sometimes babies can be very functional during a nursing or bottle stage. And the mom says, I'm not in a lot of pain. Bottles are functional, my baby's gaining. And then they go to that next stage in feeding with introduction of spoon. And then we start seeing this sensory response, or meaning the baby is really gagging on every spoon presentation and can't seem to figure out how to move the food or the puree in their mouth. And then that same, again, impact of a tongue tie can happen in that next stage when the baby starts to learn how to chew, and you give them a Cheerio and they're having trouble moving that mid-tongue enough and they're gagging a lot. And sometimes you can see that when the frenulum is a little bit too tight.
Absolutely. And that's what we're talking about. It's impacting the function of the tongue. It's impacting the way the tongue is moving to be able to achieve those, things that we do throughout the day. Okay.
So what is tongue extension and tongue elevation? So we didn't provide the whole video here. We just screenshotted it at this moment in the video because it does look like we're going to give you guys a good video. But one of the questions we sometimes ask parents and families is, do you guys see your child's tongue? Is your child extending their tongue, what we call past the labial or lip border of that bottom lip? And sometimes parents, this mother said to us, oh yeah, I see the baby's tongue all the time. So she's like, see, and she's showing us. And I was like, I want to stop and start a video. So we did a whole demonstration with her. And in her mind, yes, she was completely correct. We're seeing the tongue. And in this picture, you see the baby's tongue. But what we're not seeing is the tongue come past that bottom lip. So it becomes tricky because we're not just looking for the baby opening and seeing a piece of the tongue. We're looking for how far that tongue can extend past the bottom lip. So we ask these questions to parents. We want to know, how often do you see the tongue come out? We assessed a baby earlier today, and the mom said, at non-feeding times, I see the baby's tongue. And we even saw it, the baby goes to the tongue comes out. You could see it comes really to the bottom lip, but then the baby can't open her mouth and extend the tongue. So there's the difference of, you can see some level of tongue, but the tie underneath is restricting the baby from having those same tongue movements during mouth opening. And during bottle and breast drinking, you have to open to allow the breast or the bottle to come into your mouth and have the tongue in a really nice, more neutral and almost extended position to cup the nipple. So we talk about lateral movements. Lateral movements are movements from side to side. So we have our very handy dandy Mr. Mouth, and Mr. Mouth has a tongue, and lateral movements are side to side. And we assess this by sometimes just stroking or rubbing our finger on the side of the tongue, and the tongue follows the stimulus and comes back and forth.
Finger to see, will the tongue follow the stimulus and be able to do that appropriate lateralization that we're looking for?
And as a baby, this is a reflexive movement. If we stroke the side of the tongue should be able, so we're assessing how can the tongue come over and follow the stimulus. And this is the necessary movement when a child starts to chew. You want the tongue to be able to sweep towards the teeth. So if something's in the middle of the tongue, they could bring it to the teeth to chew. So this comes back and forth like that. So with various stretches, oral play that we're doing during the assessment. So we're looking at if we make the baby look like they have, we call it guppy, and can the side of the baby's mouth.
You're doing a little fishy face.
Mm-hmm.
Can the sides touch?
Can the child, the root reflex is still present with some of the babies we see, and we're saying, as the baby turns their head to root, is the tongue coming out to follow? So these are a lot of different things we're doing during our assessment to not only assess range of motion, but then to assess function of the tongue. So we ask a bunch of questions. Can a baby latch without a shield? Can the baby exchange or transfer milk during nursing? Can the baby maintain a latch to the breast? So sometimes these babies, they're able to latch and they suck and they keep falling off and they keep falling off, and they're falling off because their tongue is not strong enough or long enough to cup the breast tissue the right way to establish, or really I should say maintain a functional latch to exchange milk.
Absolutely. Quick one, when we are at a certain point in our assessment and we're like, okay, we think this tongue might be affecting the function, right? So these are some of the things that we might be seeing when the tongue is impacting function. And just for an example, this baby in this picture actually does have a tongue that is on the tighter end, is on the shorter end, and could be classified as a tongue tie. However, this baby, the function is not impacted. There's a deep enough latch. We do not see, like I say in some of the bullet points that you'll see on the left, we don't hear clicking on the bottle. The latch is perfect. There's not falling off. We don't want to see oral loss. It is a beautiful latch, despite having a tighter lingual frenulum. The function is not impacted. But when, so difficulty with elevation and or extension. So elevation, again, just to reiterate, bringing that tongue up to elevate the tongue, right? Extension to bring it out. So if those are difficulties, we might see less efficient sucking patterns. We might see the baby working really, really hard to suck to access the milk. They're motivated, that it might lead them to suck, but it's not those draws that are really going to bring in the milk more efficiently because they're having those limitations in elevation and extension. This might lead to fatigue for baby because they're working so hard. They might get then sleepy during feeds. Feeds may take a long time. They might not have enough exchange when that leads to snacking, more frequent feeds. Like we spoke about before, this can lead to, moms being uncomfortable during nursing, secondary to a shallow latch, a bunch of different reasons. The baby might have difficulty latching to breast and bottle in general. Poor shallow latch, frequent falling off the nipple, as Lori was just talking about, and this clicking sound that it's a very specific sound that you might hear both on the breast or the bottle, and that's a sign that that baby is having difficulty maintaining the appropriate tongue posture for feeding.
And what I ran and got were different bottles, because we're also, so sometimes the parents but they're super functional on the bottle. And we look at the depth of the baby's latch, and we look at obviously the nipple shape, because all these bottles are completely different. So we have bottles such as the Lancinol bottle with a pigeon nipple. So this is a more graded shape, so the baby can't cheat, right? Because they could either be here or here on the nipple, depending on the depth of I guess they can cheat if it's really a shallow latch. But to maintain a deeper latch, we can really see where their lips end at the edge of the nipple to assess if they're really able to draw the nipple into their oral cavity appropriately. And there's other nipples, such as the Avent, where sometimes we see babies only latched onto the tip of the nipple. So these are both Avents, and the baby does not have a deep enough latch, so it impacts function of the ability to successfully latch onto these bottles.
And so the shallow latches on both breast and bottle, or a shallow or inefficient latch or poor latch, you might see, oral loss where there's not an appropriate lip seal around the bottle. And that can lead to a bunch of other things too, like increased air intake, which might exacerbate some other signs and symptoms of discomfort within the baby. So really that latch and that function is what we're looking for when we see a baby.
Okay, so other areas that we may notice are affected by just a tongue tie, right? So we come and we meet a patient, and the patient is saying that the baby can nurse, not too much pain, they can bottle feed. But what are the impacts, like if we don't do anything about a tongue tie that we feel like really has decreased range of motion? So we've met with dentists, we work with dentists, and they talk about problems with oral hygiene later on, because these are patients who then can't get food to
clear their tongue, to clear that mouth. If something's kind of stuck and in an area of their oral cavity, they're kind of having difficulty reaching with their tongue to clear it. It might just hang out, and then that can obviously lead to, cavities.
Right. We also see sleeping concerns with
decreased quality of sleep.
Right. We see speech concerns. So the main sounds that we find are really directly related to the length of the tongue, or the range of motion of the tongue, are R, L, and TH. But that being said, we also sometimes see problems with airflow with SH and SH and SH, S, CH.
It depends on the child, but these are just the most common ones that we tend to see. It really, every single tongue is different, every single child is different.
Yeah.
So, but these are really the most common ones. Other things you might see, an open mouth resting posture. We're looking at that. We're looking at, how does the palate look? Is it a little bubbly? Is it a high arched palate? Is it unremarkable? We're always making sure it's intact in general. Any jaw changes that might be related to that tightness of the tongue, that can be present as well. So we're really looking at the full picture of the baby, which brings us to, any noted body tightness and neck posture, which sometimes, there's been research to show that tongue ties can co-occur with torticollis in some instances. So these are things we're looking for when we see a baby for the first time. We're looking at that range of motion, how they can turn their neck under their arms, just body tightness in general, the head shape, all of that.
Because the tongue is connected at the back of the jaw, that's what we're sort of talking about. So if the babies are really smart, they're probably smarter than us, and they're motivated to eat, and they compensate. So they compensate by not being able to use their tongue correctly. They figure out how they can elevate their shoulders, and they can twist and turn and sort of fix another part of the body to compensate for their tongue movements. So that's why we like to look at the whole picture. I have met adults that in their adult life have had their tongue revised, and they have been able to verbalize, not like a baby, but saying that they just felt their whole posture change in their neck because they realized how much they were really posturing
Causing that increased tension.
Yeah, and they had all this tightness in their neck and shoulders just because of the tongue tie.
Exactly. So will a tongue tie release automatically help all feeding difficulties? So sometimes we even see babies who come to us for their initial feeding evaluation, and they're still, having feeding difficulties, but they've already had a tongue tie release. And so it's almost like, is it a quick fix? The answer, long story short, no.
So
No.
we really provide that level of education because we're not saying that you go to the pediatric dentist, you get your tongue clipped, and your baby is fixed and done. Because old habits die hard. A baby learned a maladaptive or a different way to suck and have a functional way of eating, but it might not be the right way. And it's hard because then our job is to educate and teach the mom to help teach the baby how to use their tongue appropriately.
So, for example, sometimes a lot of the babies that we see, because of where the tongue restriction is, it may impact the resting posture in the mouth or their posture when they're going to suck and latch onto the breast or bottle. So sometimes, the tongue posture might be more retracted or bunched within the mouth versus a more neutral position. So ways that we're able to create, a more functional positioning for the tongue at rest and during feeding is something that, we might do some suck training, we might do oral play, things that we were talking about before, and ways to really make that change in the way that they're using their tongue and the way that they're holding it. Because even though they might now have that range of motion, they need to now use it, and we need to help them use it in a better way.
And it's like going to the gym, like you might now have the muscle, because the tongue is a muscle. So you now release the tension in the muscle, but now you have to learn how to use it. So we're like going to the gym for the mouth and the tongue, and teaching parents how they can stretch, because muscles need to be stretched. So we provide a stretching protocol after the tongue is clipped to help these babies learn that they actually have the range of motion of the tongue. And then once they have the range of motion, then they can work on strengthening their tongue.
With that, and I feel like I can speak for you to say, me and Lori are very conservative in terms of our referrals for a tongue tie revision. And we suspect that we're like, you know what, this is impacting it enough, but let's be conservative. Let's do these stretches, do these suck training exercises, make certain altercations here and there. And one of the other, bullet points on this slide too is there's other external cues that we can provide as the feeder to help make baby more efficient, right? So we want to do some of these things ahead of time as well, prior to even them being, seen by that doctor or by that specialist that's going to really be the one to determine, okay, should we go ahead with this procedure, or is it functional enough right now where you've made really, really awesome gains with these different exercises and suck training, positional changes of the tongue.
Exactly. So when we think it is impacting, function, just like Meredith is saying, that's when we make the referral. So we refer if we're going to make a referral, it's usually most often to a pediatric dentist, because there's actually two ways to revise a tongue tie. There's one that's a standard clip that can be done by a surgeon, a general person, an ENT, a general surgeon, even pediatric dentists. They use a scissor actually, and they make this diamond shaped cut. But then there's also a laser procedure, and those are really a little bit, that's where technology has brought us in the world of tongue tie, and those are usually completed by pediatric dentists. So I am board certified in lactation, but we also can make referrals to lactation to really, because we're looking at function, we're looking at the baby's ability to transfer milk during nursing. Sometimes we refer to an ENT or an ear, nose, and throat doctor, and we always discuss, what we find and what we're going to recommend with the pediatrician, because we're looking at the big picture. We're looking at weight gain. We're looking at this baby's overall, ability to thrive. So
Absolutely.
yeah.
And sometimes there's other referrals that we make during the evaluations as well, or throughout treatment as the child changes, right? Because the picture of the child changes over time, and that's our job, is to really see the big picture of the child. So other referrals we might make, even if it's not during our initial assessment, and we try to make certain changes, but other, concerns of the parent or the patient, they're presenting with certain things that we're like, you need to go see a certain specialist for this or that, whether it's, concerns with reflux or a suspected milk protein allergy. We refer frequently to gastroenterology for that, because that is their specialty. We may refer to a physical therapist, an occupational therapist. We've had patients that have had wonderful experiences with various specialists, including craniofacial specialists and chiropractors. The list is endless, but it really depends on the child.
Yeah.
And now questions.
Covering some of our thoughts and our ideas, and we'd love to hear questions.
Absolutely.
Fantastic. Thank you, ladies. Okay, so moms, if you have, or dads, if you have questions, type them into the Q&A. I have a couple of questions that came in ahead of time. Could a tongue tie be the source of a lisp or a slushy S, or even a hard time with the K and T sound?
So like we were talking about before, it really depends on the child, number one. And tongue ties can affect function in a variety of ways, depending on where the tongue tie is in the mouth, how severe it is, what's that range of motion, how is the child using the tongue, how has the child been using the tongue, is it functional, is it not, where are they holding their tongue within their mouth. And the K sound, as Lori will show you with Mr. Mouth, this is the best.
Yeah. Okay, so the K sound, if everybody was home and you did, that's actually the back of the tongue, right?
So this part,
it's not, you don't come, that's
the
ta,
T
ta,
sound
ta,
and the D
is the
sound.
T and D, but right, the back of the tongue is coming. I'm not doing a good job with this mic puppet today.
It's difficult.
It's very difficult, okay? But we're showing that during K, it's the back of the tongue.
Making contact with the palate.
Yeah, so that usually the K is not affected by a tie, but T and D can be affected. I just had a little boy who is 12 months old on my caseload. We had an identified tongue tie at birth. We kind of rode the wave. He was learning how to bottle feed, and then we were like, all right, let's not do anything. He learned how to spoon feed. We didn't do anything. He's learning how to chew, and we were kind of stuck. And he was not babbling. And 2 weeks after revision, he is happily babbling beautifully now. So we're really excited, because I think that part of his not babbling was that his tongue was pretty tight, and he was having trouble lifting or elevating the tip and moving the tongue to create really great sounds. So speech, we do see impact on speech.
And that's a good example of how we really monitor it over time. Just because we identify one at birth, like Lori said, this child was identified at birth, but we monitor it until it impacts function.
And we were like stuck in
Mhm.
therapy, and I felt like, and the mom agreed. The mom was like, you know what? Now it's impacting. I want him to be able to chew table foods and not just things that dissolve in the mouth. And he was doing a lot of gagging and a lot of little vomits because of his increased gagging during this stage in development. And it's so far so good, knock on wood. It's been really successful. We've seen a lot of progress since it's been done.
That's awesome. Another question, what age should you worry about speech sounds?
Well, that really depends on the sound, right? So the entire, every sound system, every sound in general in the, like American English language, it depends with the sound when it's supposed to come in at all, and then when it's supposed to be mastered by. So that's kind of a more general question, I would say.
But I would say that we go by developmental checklists,
Mhm.
and on a developmental checklist, according to Gard Gilman, they say that babbling or early sound development starts between 6 to 9 months of age.
Mhm.
So between 6 to 9 months of age, we're not just looking for we're looking for da, da, da. It doesn't have to be in imitation at 6
Mhm.
months of age. It needs to be in play. So we
Mhm.
want to hear early sound development or that early babbling between
Mhm.
6 to 9 months of age.
Absolutely. And the first sounds that we really look for with, the younger children, obviously, are, some of the earlier sounds, he, B, M, H, W, some of those sounds, T, D, all of those. So yeah.
Awesome. If the dentist finds a tongue tie that you never noticed or had diagnosed, should you immediately see a speech therapist?
Okay, so I think at first would depend on the age of the kid.
Mhm.
And if the dentist identifies it, maybe the parent could discuss with the dentist how they think it could be impacting their current function. So is it impacting oral hygiene and
Mhm.
cavities? Is it impacting the shape of their palate, which then dictates how dentition? Because if the tongue is not getting palate time, like where the tongue comes and rests,
Contact with the palate
The
at rest.
yeah, the palate tends to go more high arched rather than like a palate that's laying more flat. So that affects dentition. So I would definitely ask questions to the dentist specifically. And then I would have them really think about the child's speech and sound development. Is the dentist referring to some level of sound development?
Like, are they seeing that we kind of spoke about, like other things you might see impacted by this? And if the parent is seeing any of those, then choose based on what they're seeing, right?
That we're going to make the referral, or that they should make a referral to a speech therapist
Or whatever specialist they're kind of saying. Yeah.
Yeah.